Hello and welcome to episode 8 of Atrainability Radio, where I get to speak with Jacob Bayliss, who is another of the speakers at TEDx NHS 2019, where Atrainability were proud to be one of the sponsors. Jacob's point of view is about health and well-being, particularly for young and the LGBT community. And as a trans man, he has, I think, a unique attitude to it, lived experiences, as he says himself. And Jacob does a lot of work around the third sector of healthcare and brings, I think, experiences and thought-provoking ideas which can benefit a huge amount of us across the healthcare professions. I hope you all enjoy this podcast. Let's get on and meet Jacob Bayliss. Thank you so much for agreeing to do this podcast, and I think people will be very interested in your subject. That's for sure. And
very welcome.
Oh no, thank you. It's such an important topic, and I was there at the Indigo as we were sponsors of TEDx.
Yeah.
NHS 2019. I don't think we got to meet. I'm so sorry. I can't remember now.
I don't think so. It was a whirlwind of a day anyway, wasn't it? So.
Well, it was. And I felt I didn't really want to intrude on the speakers because they all had, they were under a lot of pressure, one thing and another. And so it kind of felt like you had a lot of people around you, all of you. And I don't think you needed me as well. So this is the first time we've kind of met, and I think that's great. So could you tell the listeners a little bit about yourself, please, and what led to you chatting to me today?
Sure. Well, I struggle to remember, but I'm 28, and I've been working in what I suppose you might call the third sector in health for a number of years now, 6 or 7 years. Probably longer, actually. And, through work, I came to a point where I was really involved in lots of public health work and health projects. And that was something I was really passionate about. And that really crossed over with my personal experience of navigating the healthcare system as a trans person. Yeah. And, work-wise, an opportunity came up to work on that intersection, to look at LGBT health and those inequalities. And that was something I was really keen to do because I felt, I could bring a lot to that, uniquely.
I can imagine, and, uniquely qualified, as you say. So, yeah.
Well, yeah, I think lived experience is such an important factor that we often undervalue when we think about what an expert is. Yeah. And, absolutely, there are other skills that are important too, but lived experience shouldn't be undervalued or underestimated. So anyway, that was one thing I felt I brought to the work. And so I've been working on that for some time now. And I've kind of got my head around the ins and outs of what's working and what isn't in the NHS for LGBT people. So this opportunity came up to speak at TEDx NHS to a room full of, the NHS workforce about things like open hearts and divergent thoughts. And it just seemed to fit with a lot of the messages, I find myself saying, and at the LGBT Foundation, we find ourselves saying a lot. So it just seemed like an opportunity I couldn't pass up. So I found myself there at the O2.
Yeah, and it was a most fantastic day, I've got to say. And I found the whole experience, yours, of course, included, very moving and very enlightening. I'm a much significantly older man than you and most of the people there, because I'm still learning, and a lot of this stuff is stuff that I just wasn't brought up with at all. And if I can help, or if we can help to spread that understanding a bit further, and along the way learn ourselves. What I do is run a lot of training courses. This week, I've personally run training courses for a load of middle grade, staff grade and associate specialist doctors in the Midlands. And then yesterday I did 2 half-day courses at a private hospital with ward nursing staff and pharmacists and people like that. And your story, I think we can help to fit in there because, as you say, it's very powerful what you received yourself, but also perhaps more importantly, the advice we can give them to consider. And I think your story about people being invisible and actually looking and thinking, who is this person? Have you come across this bit? I think from listening to you, perhaps you have, where a lot of patients report being treated like a case, and rather than by being the person. I think that was really the gist of what you were saying.
I think there's a lot of people who share that experience, whether it's around an element of their identity or maybe a condition they're struggling with, like, mental health might be a good example of that, where we get a bit myopic and we focus on one aspect of this person when actually the solution lies in the context and in other things that are going on in that person's life. We talk a lot in the NHS about social prescribing, and that's kind of looking at the acute problem, but actually seeing that the context is housing or family breakdown, and being able to, have that kind of person-centered, kind of whole person mindset. We use all these different words to talk about it, and different ones coming in out of fashion. But I think what kind of remains is that those human factors that we can't control, but have such a big impact on our health and on our ability and resilience when we're navigating the healthcare system as well. Yes,
I think you're right. The whole idea about social prescribing, it's something we're involved with here. I've been a member of my local Lions Club for many years, and actually social prescribing is getting in some ways harder, because with government cutbacks in social services, and also I think some of the misunderstanding around the laws around confidentiality, we're finding it harder as a volunteer organisation to actually be put in touch with the people who need the help. And, we've got the money and the resources to help people, and it goes much wider. But I want to focus really on obviously on your aspect of it. So, you're doing such a great job. In simple terms, if you could tell the listeners what you think needs to change particularly about LGBT and trans people.
Gosh, that's a big question.
Well, we've got a few minutes.
I think there are some key things that, we hear a lot and we say a lot. And I think the thing, certainly I hear a lot from healthcare professionals and from all kinds of people, is a sense of anxiety around getting it wrong, about language and not understanding. And it's completely understandable. And I think actually when we look back at, the society we've grown up in, whether we're thinking about a global society or a national society, where, using the UK as an example, there are actually laws around even talking about LGBT identities in school. Yeah. We've grown up in a society that's sending us messages all the time that these things are embarrassing, that they're not things we should be talking about. So whether you're LGBT or whether you're a clinician or, indeed both, there's nothing wrong with feeling uncomfortable. It's okay to have those feelings. I think that, where the damage happens is when we feel that discomfort and therefore we don't have the difficult conversation, or we don't ask the question, or perhaps we ask it in a way that really communicates that shame and discomfort for a person who actually might be the vulnerable person in this situation. Just talking about things and sitting with some of that discomfort and, not feeling like that makes you a bad person or you're doing something wrong, but actually kind of embracing a little bit of that and reflecting on it. Where might that come from? Eventually getting to a place where these questions don't feel difficult and they're not a barrier for, either for people to disclose or for clinicians to ask. I think that's a big one, and that isn't going to happen overnight. That happens through, people having more conversations, through visibility, these organic things that happen over time.
Yeah. I mean, one of the things, if I can just jump in, is that
sure.
This thing about sort of built-in biases that we have that go back many, many years. And I've already done a podcast with Alexandra Adams, the blind deaf girl, and it is just so moving to listen to her experience and the way she's kind of risen above it. And I mean, she's suffered so much, but yet she's achieving such a lot as a beacon, I think, of other people to follow. And I absolutely take my hat off to her, as I do to all of you who were there speaking on that day. But maybe I'm just trying to think it through, like, people like myself, to try and put myself in someone else's place. What would it be like? I think some people don't, either they can't do it or they don't know where to begin. And I think listening to people like yourself explaining what it's like from your point of view, you've certainly opened my eyes, and I've got a much better, I hope, understanding now and appreciation of the issues, which I genuinely didn't have before. And if we can help to spread that, I think that's great. But it's, I was interested. You're going to have this operation for a hysterectomy, and your worries when you said them, it hadn't really occurred to me, what gender ward will they put you on? And will they discuss your situation without appropriate confidentiality that other people can overhear? It's bad enough in my local GP practice. You go up to the desk and, yes, what's wrong with you? And you don't want to say, well, I've got such and such a problem. And what would your advice be for people out there on the other side? So say your GP practice, how have they dealt with it effectively, Jacob?
Actually, my GP practice is fantastic. And my GP is very, very knowledgeable, and it's actually a member of the community themselves. So I'm quite lucky, and it's a bit of an exception really to the rule, but that's not the only positive experiences or relationship I've had with a GP. And I often say that you don't need to be an expert, and you don't need to know all of the words to get it right for people. It can be much more basic than that. And I think, in my talk, I talked a little bit about delivering good healthcare is a bit like making a cup of tea. Like you don't know how to combine the ingredients unless you ask. And I think that those honest conversations where we kind of lay our cards on the table and say, this is new to me, but I'm here and I'm listening, and communicating that mutual, having that relationship of mutual respect. It doesn't require you to necessarily know all the words. It just requires you to create a space where someone can tell you what they need and you can be led by them. But that does need to come from a place of confidence. And often what we see with clinicians is, for all kinds of reasons and completely understandably, when there's so much pressure put, on GPs in particular, such short appointments, but reacting with anxiety or worry or panic, and actually closing down that conversation and not creating an opportunity for the patient to really lead you to getting it right.
Yeah. So has your GP, you said they're part of the community, which is extremely fortunate, or maybe you chose them, but have they managed to communicate the same understanding to the rest of the practice? So the receptionists and maybe practice nurses and whoever. I mean, do you always get to see your own GP? Because at my practice here, I haven't seen my own GP, even in the street, let alone in surgery, for 4 years. Not that I go very often, but
No, you're absolutely right. It's lucky when you get to see your own GP, for sure. No, I come into contact with all kinds of people at my local GP surgery, and I can't, backing my mind now, in recent years, I can't think of a time where I've had a negative experience. And actually, for a trans person to say that is uncommon, sadly. But I think that while my healthcare journey, at times my identity has been a really big part of that. A lot of the time I'm going for other reasons. And I think it's equally important for clinicians to recognise when it's not relevant. And my practice does that really well too. We hear a lot from the community that there's a bit of an inappropriate focus on this one factor, when in fact, I talked about the context, and there's other much bigger things going on in their lives or in their health that aren't relevant. For some, they feel impeded by this. Clinicians worry about, for example, the hormones they're taking or the surgeries they may or may not have had, when in fact it's not relevant. So, actually, my in recent years, in the past, when I was beginning my transition, most of the time when I was having contact with healthcare professionals, that's what it was about. But these days, it's hardly ever about that. Yeah, sometimes it is, and I'm just treated with respect, and all the professionals I meet are lovely and friendly, and that's great. Yes. They're getting it right, and they're not doing anything uniquely. Actually, there isn't sort of a silver bullet, but I think when I do raise it and when it is relevant, the clinicians I come into contact with at my practice know enough to know when it is and isn't relevant, and when it is, they know enough to be able to point me in the right direction and give me the right advice, or say I need to go away and find out more, and that's a great response too, as far as I'm concerned. That definitely encourages me to trust someone more when they're willing to say that they need to go away and find out more.
I'm just wondering, when you go into to have the procedure, I think you said next year, or is it this year, 2020? But I just wonder, if you can have a discussion, if it's possible even to have a discussion with the people who will be looking after you kind of up front and just say, this is how I'd like it to be. And I don't know if there is that opportunity even, but it would be great if there was. I
agree. Yeah. And it's a good question. I'm not sure, I'm still haven't gone through that process yet. So I can't speak, from personal perspective as to whether that would happen, but I certainly hope it would. But it would all need to start with that initial kind of really knowing that, I suppose it's obvious when you see somebody coming in for hysterectomy who kind of is presenting as male that might be a question you need to ask. But if it's not in my paperwork, if they're not asking the question, then they're not going to know that they might need to make a little bit of extra time in that initial consultation to explore those things. So, one big issue that we have across LGBT health work is the lack of evidence, the lack of kind of population data that we currently have around this community. So I'm always banging on about, it's not very sexy, but asking the demographic questions. Not everybody wants to answer them. That's absolutely fine. But when we don't even ask the question, we're not giving people that opportunity to disclose, and then we're not giving ourselves the opportunity to then be person-centered and adjust the care that we're giving in response to that.
Yes, I mean, one of the problems I suppose that you face in a way is that, I think you said in your TEDx talk at the beginning, that you actually look quite normal. If you'll forgive me for saying that, in other words, people will make assumptions, which they always do, and they'll judge on appearances, I guess.
Sure.
So, I know you don't want to go around waving a great big flag, but on the other hand, if you can head off embarrassment all round and unfortunate and inappropriate comments, if we can head them off up front, then, hopefully it'll be a win-win for everyone, yourself included, but also for the other staff and all the rest of it. And, I'm just trying to think, well, maybe even this podcast will help to go that way. Wouldn't that be great?
I hope so. Yeah. I mean, we know, for example, that as time goes on, we're going to see more and more people kind of identifying as either trans or non-binary. We can see when we look at the population, when we split it up, that kind of under 25s are much, much more likely to sort of consider themselves to sort of fall within this community. Like I said, population data is an issue. So all we have are approximations, but I think the current approximation is around like 500,000 people in the UK identifying, within this community. So, it's a small but not insignificant number of people, and it's growing. And I think, you talked about those questions that I raised in my talk, like what's it going to be like? Which ward will I be on? And we, for so long we've had a society and a system, and including the NHS, that's worked in a way that only has space for what we call a kind of a binary of gender, so like male or female. And other examples of a binary would be like night and day, hot and cold, on and off. So it's this kind of one or the other approach, this black and white approach to gender. And society is changing, and I think there's going to be a point where, and there already is, when we look at things like cervical screening, where the system is being stretched and bent in ways it can't cope with. But it's not up to people to kind of fit themselves around the systems. It needs to be the other way around. So I think that we're, and the NHS is moving in this direction slowly but surely, where they're kind of saying, well, actually, the system isn't fitting the people who use it, and we need it to change.
Yes, I mean, it's interesting from my point of view. Training, as we do, is in human factors. It's the NHS is having enough trouble accepting human fallibility in a sensible way, and learning from excellence, as well as learning from when things don't go so well. It's having enough trouble with that. To take it, into all the other things, as you say, that society is changing. Can I just come back to, you just mentioned cervical screening, which was one of the things that struck me. I think you said in your talk that there's a lot of lesbian and bisexual women who don't appreciate that they should still have cervical screening. Did I get that right?
That's right. The statistics I'm aware of are about 40% of women who have sex with women have been told either by a friend or often a clinician that they don't need screening. I mean, I've spoken to so many people who've been told by, a nurse who does screenings or their GP that, oh, you don't need that. And I think the misunderstanding comes from how kind of the HPV virus travels and people not thinking about other kinds of skin-to-skin contact or other kinds of penetration that people might be engaging in. But it's a very kind of narrow-minded approach to screening, and lesbian and bisexual women are just as, I suppose, at risk, we could say. So it's a real issue, and one that public health, I think, is taking really quite seriously at the moment. There's quite a lot of work going on with charities like Joe's Trust, but also, public health around how do we ensure that these women aren't being missed.
Yes, gosh, that's amazing. The other thing that struck me, you were saying about 50% of trans people in the UK attempt suicide. And I mean, that's a shockingly high statistic. The idea that have you come across the making every contact count?
I have.
Yeah. And do you think that's something which is appropriate here?
Absolutely. It's something I talk to clinicians about a lot. And, I'm always keen to say that, being trans isn't, necessarily linked in any way with having, mental health issues or conditions or anything like that. But, we looking at these statistics, we know that this is a huge issue in this community, and there's all kinds of factors that feed into that, I think. One that I talk about a lot are the very long waiting lists for the gender identity services that we have at the moment. And when a clinician sees someone who's at the very beginning of this journey and wants a referral to a gender identity service, we could be talking 5 years. I think things are improving, but we're talking years, not weeks or months here before people get seen. So I always say, it's great that you're making that referral, but we need to think about how, exactly how can we make this contact count? What else can we do for this person? This is where things like social prescribing or, thinking about how this person is faring, what's their well-being like. It's so vital. So knowing what we know, that the suicide rates are so high, it's an opportunity to ask kind of and manage expectations. You are going to be waiting for a long time. How is that going to make you feel? Do you need additional support? Because there's some really fantastic, community-based support out there. That's one thing the LGBT community does well, is kind of organising all kinds of, groups and support and things like that. So, clinicians need to be plugged into that, because it's a missed opportunity if they don't let their patients know about these things.
But I guess a lot of teenagers who are struggling with, the effects of puberty and hormones building up and all the rest of it, and potentially getting some kind of abuse on social media in these days, which is seemingly 24/7 if you're not careful. It's about, I suppose, maintaining their equilibrium and giving. I think that, it's a long time ago I was a teenager, but there's always that feeling as a teenager that you're the only one and you're on your own, and it's finding someone to turn to as a friend, as a listener, as a sympathetic or an empathic ear. Do you have any thoughts about that, Jacob, in particular? Or
well, I think before I did this work, I worked with the YMCA, so did a lot of work around young people's mental health, and I agree, wholeheartedly. And there's so much power in that kind of visibility and representation in all kinds of areas, whether that's kind of a young person seeing they're not the only person who's struggling or who's having these feelings. And like you said, it can feel like when you're feeling this way for the first time that you are the only one. And, often that really isn't the case. And I think that, that absolutely extends to people who, are LGBT and who might be exploring that for the first time. We see really high levels of isolation. We've talked about mental health, and I think particularly for LGBT people who are maybe also people of colour, also have disabilities, also in communities of faith, I think that becomes doubly important, because that representation is just missing at the moment, both in the LGBT community and in society in general.
And, I think it expands beyond. I'm going to take it away from LGBT just for a moment, because
Sure.
yesterday I ran a training course, and there was this, I don't think I've mentioned this already, but there was a nurse on the course yesterday who became a nurse, took up nursing quite late in life. Well, by late in life, I mean late 30s, I think. And I said to her, why did you do it? And it transpired it was because she'd received absolutely appalling care when she was in hospital herself. And it took what reminded me was you saying about being invisible and people not listening to you and not asking you and finding out who you were. And that was what she experienced, was that she was on drug therapy that was inducing hallucinations. And she was trying to tell the nurses, they just ignored her. And she's gone on to become a cancer specialist now, and she's trying to do anything but that. But some of the stories she told me about, people just not listening to the patient at all is, and the same thing, I guess, in maternity services, listening to the mother. The patient knows their own body best, like your own situation, like nobody else ever will. And so what I'm trying to get to with this is, I'm not trying to hijack it away from the subject, but specifically, but just for people to think, you have a person in front of you. And because we so often get asked to go into organizations in trouble, failing organizations, often it's because they've just ignoring the person. I'm back to this bit about seeing the case. For me, your story, Jacob, has really highlighted that, in huge capital letters. I want to really thank you for that. Is there anything else you'd like to add that we haven't talked about yet?
Going over what I've kind of mentioned already, because the first question you asked me is like, what can we do? And the first thing I kind of said is talk about it, get comfortable with it, embrace the discomfort, just get stuck in, get your hands dirty. It might feel awkward and difficult at first. I've had some clinicians who've actually just practiced saying some words out loud that have made them feel uncomfortable before. And if that's where you start, that's where you start. It's great. Be curious, talk about things, ask questions. Don't be embarrassed not to know the answer. Then the other thing I talked about was kind of monitoring, which isn't as exciting. But I think when we're looking kind of nationally at what we want to change and what we want to influence is such an important kind of tool in our toolkit. We need to know who's out there, and almost all NHS services, I think, are mandated to ask about ethnicity, and that gives us some really important data about risk and prevalence, but also about who's using our services and who isn't getting through the door. And I think we need to broaden that out and make sure we're doing that for other communities who get missed in healthcare as well. So although those tick box, what we sometimes talk about tick box exercises, and that already sounds quite dismissive and flippant, but they maybe don't sound exciting, but they open up so much potential for a service to improve and for service planning to improve. So I think that, I bang on about it all the time, but that would be the second thing I would really push. And I think the third is just for healthcare. You talked about seeing the person and seeing the patient. And I think that the NHS is under a lot of pressure. When a service is busy, it's easier to become more and more closed off to doing additional things. But, particularly services in the community where they can open themselves up to putting their heads kind of above the NHS world and clinical world and going, what else is going on in my community? Is there a seniors coffee morning? Is there like a trans swimming session? These are all things going on in London and having a huge benefit on people's lives, livelihoods, well-being and health. It's just that, linking up in a more holistic, joined up way with all of these things going on. So, certainly in general practice, but in secondary care too, and other, health and social care and things like that. It's just recognizing the value in this joined up system where everybody brings something to the table, and trying to make sure that when we're seeing a patient with all kinds of factors, that we're meeting their needs, creatively, not just through clinical pathways.
I mean, in simple terms, it's about starting with an open mind. But I think, one of the simplest things which struck me, I'd never really thought about what you do, the pronoun bit. How do you, if someone starts with nothing more than saying, how would you like to be addressed? I'm an older man, and I find so many people have never met me before, and they start by calling me Trevor. And I think, well, that's okay, but I'm not entirely comfortable with that, especially if it's someone from the mobile phone company, asking me about.
Sure.
Hang on a minute, and it actually, you extend that, and it's the same thing for you. How would you like to be addressed? And the other questions that you said, what's your gender? Have you been different from birth? And what's your sexual orientation? I think I might hesitate to start by someone saying, "Hi, we've never met. What's your sexual orientation?"
Sure.
But I think we've got to start thinking along those lines, and it should be okay to ask it and okay to answer it. Yeah.
Yeah, and I think that you're right. It's around like it almost feels like, oh my goodness, why would you ask that question? And it might not be something we want to hammer out within the first 2 minutes of meeting someone, because it's not always relevant. But
quite so. But if you're in a healthcare setting, maybe it is.
Exactly. So it's important not to miss, because I always think that can be the golden nugget that means you get it right. Otherwise, social prescribing and things can be ineffective if we don't have that whole picture of what might work for someone. So it can be the little piece of information, the little piece of treasure that means that you get it right for that person. I suppose the other thing I just haven't touched on is there's a saying, I don't know if you've heard, like, you can't be what you can't see, about representation. And I think it's about supporting the LGBT workforce in the NHS. I don't think we've talked about patients a lot, but there's a fantastic, there's so many LGBT people working in the NHS as clinicians.
Of course, yes.
And they're a big piece of that puzzle too.
Of course, yes, we haven't talked about that.
It's about, looking after your own as well, because seeing, LGBT clinicians kind of modelling, all kinds of things, good health, and representing kind of all of that, it gives people, I think it makes people more kind of aspirational about not only what they can be and what they can do, but also looking after themselves and kind of thinking, well, this healthcare service is for me, because I can see myself reflected in. And
on that note, you were so lucky to find an LGBT GP. So it's for you, that's perfect. And
absolutely,
yeah. And there must be plenty more out there, and perhaps not all of them are out. I'm guessing.
I have heard a lot of staff in the NHS say that they didn't feel that was something they could be open about. For all kinds of reasons. They felt it might damage their career prospects and things like that, which is really sad to hear. I think that's changing, but I don't think that these things change overnight. So it's something to be mindful of. But where we do have LGBT clinicians, we really do see the impact. We see a lot of LGBT people kind of preferring to be seen by someone who gets it. And I don't think that's kind of a sustainable solution, but it does show us that the need is there and that people really respond positively to seeing that.
Yeah, well, it's about being able to relax with a clinician, so that you can, when you relax, you're more likely to, I suppose, give them the information that they need to properly diagnose you and to properly treat you.
Absolutely, yeah, for sure.
Well, that's wonderful, Jacob. I think we've kind of come to a natural conclusion, if you feel that way.
Yeah, no, thank you for calling. It's good to be able to kind of go over some of the things. It feels like so long ago. It was only October, but it was nice to kind of revisit some of those things. And I'm really pleased to hear that you enjoyed the day and there were some messages you took away from my talk.
Loads. Thank you so much, Jacob. Thank you for your time and thank you for your insight and for sharing it. And I think it's so valuable, and I think listeners will really gain a lot from this talk. And
you're so welcome.
Brilliant.
Anything else you need, you know where I am.
Yeah, no, thank you very much. We do indeed. And if you've got any other thoughts or ideas, please do share them. We can always revisit and expand it. So
okay. Thank you so
much.
Bye now.
Bye. So it was a real pleasure to share a conversation with Jacob Bayliss today. I'm very grateful to him for his time to appear as a guest on Atrainability Radio. That conversation has given me plenty to think about, and I hope I'm a little bit wiser now, and I'm sure you'll feel the same. You can find the show notes for this episode at our website on Atrainability Radio at www.atrainability.co.uk. Just search for the episode with Jacob Bayliss. Within those show notes, you can find links, which I'm sure you'll find useful for other resources. Please do help to spread the word about Atrainability Radio. Tell a friend and share it with colleagues perhaps. And if you've not already done so, you can subscribe to the podcast on iTunes or wherever you get your podcasts. So until the next episode, I remain Trevor Dale, and this has been Atrainability Radio.